to talk about this class of medication called the steroid, because they will always ask you about steroid in the exam. So you just need to know, the classification. You know, it comes in the super potent, potent, moderate, and least potent. So it can come in the exam in different ways. So there's no other way to know these things except you memorize it. But this is one of the exam questions. Especially they can ask you about the super potent, but they are going to be specific, the one they want you to answer. If it's lower potency, they will tell you. If it's moderate, they will tell you. If it's super potent, they will tell you. The problem, you know, is kind of hard for people to remember, but there's no other way to remember except going through it again and again. That was what I did. I had to write it down, and you are going something like that. So if somebody have something at the eyelid, at the face, at the intericnous areas, and the genital, what do we use? We use the low potent. So that is how it will be in the exam, which is the hydrocortisone. That is the least one. That is the low potency. Okay. Then we have another one, moderate to high potency. This one is we use it for thicker skin. When you're talking about the scalp, the sole of it. So just imagine it. It's more of moderate. So something like psoriasis. Okay. So this is mostly your moderate. An example of your moderate is your triamcinolone or Kenalog, okay, or Kenalog. Then we have another one that is that also use, which is the super potent. Okay, example is the clobetasol, okay, or thermovet, but you're always going to see this word, clobetasol. Okay, it's usually super potent, okay, but they have the risk of hypothalamic or pituitary axis suppression. So however you can use to remember it, I know I was trying to remember it during my own time, you know, however easy, I kind of put something like this, CHTH, okay? Whatever you can use to remember it, that is fine. And my C is the super potent, which is the clobetasol. Then potent, which is always your log. So many of us are used to log. Then moderate, which is always your triamcinolone or Kenalog. Okay, and the last one is hydrocortisone. Bet me if you don't remember any of them, try to remember the moderate one. Moderate is always common, which is Kenalog. If you are working in the hospital, you always see that one being used. Also remember the super potent, and remember the least. For the least one, is always common to ask, and that is your hydrocortisone. So don't mix it up, please, because you're going to see it in the exam. They're going to be specific, and they're going to ask you which of the following is a moderate or least or lowest or least potent, and they're going to list all this medication, and you're asking yourself, but all this thing is steroid, so what is these people talking about? They know what they're talking about. Sometimes some of all these little things, tiny things, people read them, they don't pay attention to them. You will see it in the exam. Most of all those places that are really forgotten, don't forget this class of steroid. You will always see it. So however you want to remember it, you can always remember it, okay? CHTH, okay? So always remember your potent. You can close your eyes as we're saying it. Potent is always common. Is your halog. Moderate is always common. Is your Kenalog, okay? is your Kenalog. Then the last one is your hydrocortisone. Everybody knows hydrocortisone. I don't think somebody will fail hydrocortisone, but just remember that. Then there's another thing you need to know for the exam, drugs that require eye examination. You are going to see it in the exam. They're going to tell you a patient is on this medication. What is the priority or whatever? There's a way they will put it in the question. And you're going to ask yourself, you're going to see something like yearly examination, eye examination. And you're asking yourself, how did eye examination come into this? So most of the time, when somebody is on digoxin, eye examination is important because it changes, it can cause yellow to green vision. Then ethambutol, that is another one. Then corticosteroid, it can cause cataract, glaucoma. Then fluoroquinolones can cause retinal detachment. But don't forget this Viagra. I'm just telling us some medication, but the most common one you are going to see in the exam is Plaquenil. This Plaquenil. If you want to study more about that, study more about that, okay? But this medication, they will always ask you, what do you educate the patient as a provider? What do you tell your patient or what do you recommend or whatever? But the most common medication you are going to see for this, there are all the other ones, you can take note of them. You can take note of the Accutane. You can take note of the Accutane. You can take note of the Viagra, but I'm just telling you the most common one you will see. So don't forget Plaquenil. So many of us know it as hydrochloroquine. Hydrochloroquine. People from Africa, they are used to that, hydrochloroquine, okay? So it's like an anti-malaria. So that is why people from Africa or countries that have malaria, they will always know hydrochloroquine, hydrochloroquine, okay? That is your Plaquenil. What do you educate the patient? Educate the patient for yearly eye examination. That will just be the option, yearly eye examination. So all these medication I listed here, you can see any of them. You can see any of them. Drugs that require eye examination, digoxin, ethambutol, corticosteroid, fluoroquinolones, Viagra. Viagra is the one we use for erectile dysfunction, okay? Accutane, we already know about Accutane, the one we use for um, severe acne, acne vulgaris, okay? The one that we say that if a patient is on acne, before you give it to the patient, they have to do pregnancy tests, and you only give them 1 month supply. You cannot give them more than 1 month supply. They're going to check for pregnancy when they come back, and you educate them, they have to be on 2 birth control. And another one is a topomas, because topomas can always cause, it can cause all these complications, acute angle closure glaucoma. But don't forget Plequenil, even if you don't remember the other ones, okay? Then FDA category S. So FDA category S, is just to let you know some of the medications that cautions or that should even be avoided pregnancy. As far as it depends on the person, you have to educate the patient. One of them is your Prosca. Always buy Prosca. They give to patient BPH, right? So this Prosca, a pregnant woman cannot touch it with a bare hand. That is what you will see in the option, Prosca. They cannot touch it with a bare hand, okay? They cannot touch it with a bare hand. Be that they cannot touch it with a bare hand. Another one is Accutane, is category S. And this is what we emphasize, or research emphasizes, that a pregnant woman cannot be on Accutane. And you have to be sure that the pregnancy result is negative. Then the warfarin and the misoprostol, then the rest. And also remember your live vaccine. We cannot give live vaccine to a pregnant woman. And if they ask you a question about a pregnant woman and have, the titer for maybe measles or varicella, that is what they always ask. So what do? You are not going to give it to that woman while she's pregnant. You are going to give it after delivery, postpartum. The answer is usually postpartum. So don't forget all the medications, category X. Then we move to questions. If they ask you, you have a 12-year-old patient that presents for evaluation of painful pimple. The buzzword here is painful pimple, painful. And another buzzword here is on the eyelid, on the eyelid. On exam, you find a 3 millimeter punctate pustules on the margin of the right eyelid with no exudate, what is likely to be. So once you look at this option, like I tell in the exam, it's as easy to remove two options right away if you know what they are talking about. So what do I mean by that? Definitely it's not going to be molluscum contagiosum. Molluscum contagiosum is a dome shape. When you listen to my video, it will be easier to describe all these things. It's dome shaped, central umbilical, umbilicus and a white ring. And we say that if it's found at the genital area, you suspect abuse. So when you want to differentiate, and that is why the exam you have to, if you throw away molluscum contagiosum, you throw away Bephlitis, it's remaining chalazion and Holedium. These two things looks alike. Chalazion and Holedium, they look alike. But the only difference is that chalazion C is chilling, which is what? It doesn't hurt. Holedium H, H goes for hot, is hurting the patient. That means it's painful. So that is how to differentiate it. If they say that this patient has a painless, then that is chalazion. But the fact that painful, that is Holedium. And I believe all of us got the answer. So I give you time to think, you put the answer, and I know for sure that the answer is correct. Then the nurse practitioner is checking for strabismus. What would the nurse practitioner use? The answer is your what? Cover and uncover test. Okay. So you should know what Isharisha or Aishahara test is used. Chinel test is used. Chinel test is your acuity, visual acuity. Sahari test is used for color blindness.
Yes.
Then we have another question here. You have a 38-year-old female, and this female has an acute onset episode of dizziness and nausea. And this began 2 weeks after the resolution of a cough. All this thing is giving you buzzword. She says that it feels as though the room is spinning around her. As though the room is spinning around her, and the sensation is worse when she suddenly moves her head. She has tinnitus and some hearing loss at the left side. Her past menstrual history is significant for type 2 diabetes and hypertension. She's been treated with metformin and enalapril. Today, her blood glucose is this. Which of the following is the mostly likely etiology of her complaint. If you know this answer, you don't even have to waste your time. These are the answers that are straightforward because this cannot be hypoglycemia, this cannot be migraine, and that is only two you can work with. But definitely you need to know is labyrinthitis. Labyrinthitis is what? Inflammatory disorder of the inner ear, the labyrinth, okay? So people that have this condition, it always produces disturbances and balance and hearing issues. So definitely this one is a very easy question. It's straightforward. Nobody should fail it because we know what is hypoglycemia, okay? We know what is migraine. So it doesn't relate with any of these symptoms. She says it feels like though the room is spinning. And other places you're going to see this is like mania patients, you know, they will have ringing in their ear. It feels like, or BPPV. So any of those paroxysmal positional vertigo, that is where you can see all those things. But the buzzword here, it feels as though the room is spinning around her, and it gets worse when she suddenly moves her head. That is the buzzword. A nurse practitioner is examining the hands of a 67-year female patient that notes bony nodules located at the distal interphalanges. So where is the distal? The distal is away. So remember, they want you to say, what is this? So distal is away. Which of these is that? So this cannot be swan neck deformity. Swan neck deformity, that is not it. So you are going to be left between Butcher's notes and Hebden's notes. So which one is farther away? The one that is farther away is your Hebden's notes. So how do you remember Hebden's notes? When somebody is trying to smoke a herb, Hebden's notes, Hebden's, that is distal, away. But Butcher's notes is your proximal, PIP. Hebden's is DIP, distal, because that is how they can ask you the question. They can tell you about Hebden's, then you need to know that Hebden's is your DIP and distal interphalanges, okay? And they can ask you about PIP. PIP is proximal. Your proximal is your Butcher's notes, okay? Where do we have, another thing you need to remember, people that have rheumatoid arthritis, they are going to have swan neck deformity. Osteoarthritis, they don't have swan neck, okay? Rheumatoid have swan neck deformity, and rheumatoid also have Butcher's notes, and another thing we call butonoreal deformity. If you listen to me in the video, you're going to hear butonoreal deformity. That is what they have. But osteoarthritis have only Butcher's notes and Hebden's notes. Butcher's notes and Hebden's notes. There is no Hebden's notes in rheumatoid arthritis. There is no Hebden's notes in rheumatoid arthritis. Which condition is associated with wearing ill-fitting high-heeled shoes? Whenever you hear high heel, somebody wearing high heel, remember they are talking about Morton's neuroma. What is Morton's neuroma? They can also tell you in the exam. A patient have this, it feels like they are standing on a pebble between the third and the fourth interphalanges. They are standing on a pebble. They are standing on a stone, okay? So this Morton neuroma, we say that what they do, they do a test called Mulder test. Mulder test. Everything I'm saying is in the videos. I'm just kind of refreshing your mind. Mulder test. Okay. Morton's neuroma, Mulder test, and that is our MOM. They can ask you about the Mulder test. What test do we use? Mulder test, which is also known as squeezing test. Squeezing. So that is your northern neuroma. Okay. Plantar fasciitis, you can also see in the exam, is always talking about the plantar fascia, like people that stand up for a long time. It's usually happening to nurses that work 12 hours, happening to police officer, people that stand a lot at their job, they always have this huge pain. And another thing they can ask you about that, what condition worsens plantar fasciitis? I remember I said pits planus. Okay, you will always see all these things there, but it worsens because this is also known as a flat foot. Okay, pits is also known as flat foot. Okay, so people flat feet. All these things is just mind you what you already know. So the flat feet. So flat feet, another question they can ask you under flat feet or pes planus. When a child is 2 years old, it is normal. So they can ask you 2 years old, if you're doing FNP, it's normal for a 2 years old. But if the person is an older person, people that have a flat, it can worsen their plantar fasciitis. The other thing of plantar fasciitis, if you're taking ANCC, they can ask you what are treatment or the management. They can tell you select 2 that apply, select 3 that applies. But always remember the treatment for plantar fasciitis, we start with NSAID. We also do NSAID, and they can also do plantar stretching, okay? Plantar stretching, and they can also send them to orthotics to make a special form of a shoe or heel, something like that, okay? That is your plantar fasciitis. They can give them diclofenac gel to help with the pain, said, okay? And we know what is a caudal equino syndrome. So caudal equino syndrome, usually, I called it a saddled anesthesia. Saddled anesthesia, somebody, maybe they have a injury, surgery, whatever, injury, surgery, and all that. And patients begin to have what we call saddled anesthesia. The patient tell you they cannot feel their butt. They cannot feel anything down there. They start peeing on themselves. We call it incontinence. Incontinence, they have bowel and bladder incontinence. So the exam can ask you, what do you do? The answer is send the person right away to ER, because there is a compression of the nerve. This has to do with the spinal cord compression. So send the person out immediately to the ER. Okay, that is your caudal equino syndrome, and it's a medical emergency. Medical emergency. When patients start complaining, maybe they have like a fracture, maybe they have like a surgery, what else, sciatica, and you remember, what test do we use for sciatica? We use a straight leg test. Leg test. Okay, I'm saying all this, and I'm saying because I believe you are listening to me, and it will keep making sense when you listen to me. You know, if we are not even getting what I'm saying, that is fine. By the time you listen again and again, you'll be nodding your head that there was a time this was said. So please, Helius rigidus doesn't really mean it's just a disorder of the joint located at the base of the big toe. Big toe. It causes pain and stiffness in the joint. So it doesn't have anything to do with what we are talking. But that is samples. Then you have a patient that presents with rash for 2 weeks. The rash is present, at the hands. So look at this question. Where do we have the rash? At the hands, at the arm, at the genital, or genitalia? The buzzword here, it is intensely pruritic. It's very itchy. especially at night. That's the buzzword. Very pyrrhetic, it's very itchy, especially at night. That is the buzzword. Two of the older siblings, okay? Two of the older siblings have a similar rash. The child does not have fever. Examination is normal except for assorted purples, vessels, some in linear array, especially at the web spaces of the fingers. So all these things they are trying to tell you, you should already know is scabies. So how do we know scabies? Scabies is intensely. Don't forget this word, intense. Scabies is so itchy. It's very, very itchy. Okay? And that is why, and we said we can also use the word interdigits, interphalanges, interdigits, interphalanges, okay? And we said that even if you don't say that have it, you are going to treat the whole family and you are going to educate them to wash everything in hot water, okay? We have pediculosis corporis, all those is function. We have tinea corporis, all those is fungal infection. You should remember your tinea. If you listen to me, tinea capitis, the one that is happening at the head. Tinea corporis is also known as your ringworm, but they're not going to use the word ringworm because it's a medical exam. So the ring is a annular rash. And we say that it has a central clearing. The difference in this one, there is no bullseye lesion because people confuse it with disease. There is a bullseye lesion, but this one is an annular rash with central clearing. Then we have your empatigo, which is the empatigo. You have your two types of empatigo, bullous and non-bullous. Empatigo is honey crustaceans, honey crusted lesions, honey crusted lesions. So what is bullous empatigo? Bullous empatigo is the one with blister. Non-bullous is the one without blister. And I said if it's non-bullous without blister, treatment is usually your plan. Ointment, all these things is in the system review. If it's bullous, and if it's bullous, I said it in one of the videos. Any condition that is mild, you don't need a patient, you don't need to refer the patient for ER or specialists. We always use what we call KCD. KCD is your effortless clindamycin dicloxacillin, okay? But if it's something that is severe, something you need to transfer the patient, something you need to refer to specialists, we use BCD because you're worried about complication, you are worried about infection, you are worried about something that will happen. For example, something cellulite, you just give the patient, because this is one of the questions you might see exam, cellulitis, and patient you gave the person effortless, and the patient is complaining of redness, pain, worsening pain, redness, all those things, edema. What do you suspect? The answer is DVT, deep vein thrombosis. Please, everything that I'm saying makes sense. Everything I am saying makes sense. But it's going to make more sense to you if you listen to me again and again and again, and it's begin to flow. Okay, everything makes sense. Don't neglect any point. Don't neglect any point. Okay, and anything that you need to refer the patient, we BCD, which is you're worried about MASA. If you're talking about treatment for MASA, then you use bathroom clindamycin, cyclin, not dicloxacillin. Okay, doxycycline. Doxycycline. Which of the following statements
I can't hear anymore.
Are you there?
Yes.
I think her internet went off completely because you can see the sign beside her name.
Even earlier, she was glitching. I couldn't hear her clearly.
Mm-hmm.
remember, antihistamine, you have to slow tapering after chronic use is indicated due to risk of cholinergic rebound. So anything antihistamine, and that is why you don't want people to use it for a long time. You don't want people to use it for a long time. So always remember that that is the most correct statement. Antihistamine, they have to, taper it down slowly. Always try to use it, but someone wants to use it a lot because of how effective it is. But you have to also educate the patient, they cannot do that. So that is the only correct option there. So you evaluated a 1 day old newborn, 1 day old, 1 day old. This is for people taking FNP. Newborn Japanese American male in the newborn nursery. Due to a skin discoloration of the lower back, the child appeared otherwise well. Multiple family members were said to have had a similar areas noted sometimes in childhood. Examination revealed a 2x2, 2x3 bluish patch overlying the sternum without any other. So all this thing is the buzzword, without any other cutaneous markers overlaying the spine. No similar area were noted elsewhere. So what is it? This is just your Mongolian spot. If you know what is Mongolian spot, you can look at this. It's like a birthmark, but it will clear away. Some of them is like a big, you to see it like they describe it, 2 cm by 3 cm, bluish gray patch. And the question said that most of the family member had that. So this is not abuse, because in this kind of question in the exam, you have to differentiate it with abuse question. This is not abuse. This is just Mongolian sport. So if you're taking ANCC, they can show you the diagram, then you point out, and they are going to show you the large area that is covered. Okay, so there is no need for biopsy. There's no need for right. So questions like this, very simple, very simple. You go to the next one. Okay. Then you have that presents the nurse practitioner for evaluation of what the client is equal and reactive. The client denies any thinking on the arthritis, all of what the painful. This is combination.
She's out again, right?
Yes.
Yeah.
Eye. Once they tell you itchy eye is always pointing conjunctivitis. And another thing you need to know, like I said, conjunctivitis is painless. But the other ones we mentioned, corneal abrasion is painful. And I said that for corneal abrasion, you need to remember you cannot give them steroid eye drop, okay? You only give them antibiotics or something for pain, okay? Then glaucoma, we have two types of glaucoma, open angle and close angle. Open angle is just chronic. Open angle is just raised intraocular pressure. Patient already know they have glaucoma. They have been managing their glaucoma under the ophthalmologist. They have been doing their best, so they know they have glaucoma, open angle. The only thing you do is if it increases more than 22, millimeter something mercury, you send them out. That is the only time. But if not, a patient is fine. Some book will tell you 24 and above. Why some 22 to 24? That is fine. But you have another thing to know about open angle glaucoma. They have loss of peripheral vision. It moves from peripheral vision to what? Central vision. So in the exam, if they ask you loss of peripheral vision, that is your open glaucoma. And another thing you need to know is the close angle. Close angle is the acute onset. One thing you need to know about all these things, you need to know the specific buzzword for each condition. You cannot just tell me eye pain. Everything will have eye pain. Every eye condition will have redness, eye, or pain or painless. That is not the specific word. But when it comes to open angle, what you are looking for is gradual, is chronic, gradual. Patients have it for a long time. They have been managing their glaucoma. They have loss of peripheral vision. And they have another thing. The only time we refer them is if their intraocular pressure is greater than 22 to 20, as in 22 to 24, depending on the source you are using. But we have a closed one. Closed angle is sudden and acute. This is the one that patient will come in with a complaint of a severe pain. And when you look into their eye, you are going to see cupping of the optic nerve. Cupping, C-U-P-P-I-N-G, cupping of the optic disc. This one, you are going to close the door. Close the door, send them out to ER. So remember, closure, close the door, ER. Closure, close the door, ER. That is your close angle, okay? Closure or close angle glaucoma, closure angle glaucoma. So that is it. And definitely, you just need to know that for glaucoma, that you just need to be able to differentiate the one they're talking about. Are they talking about open or close? But the description will tell you what they're talking about. Then you have your iritis. Iritis is a common type of inflammation of the iris called iritis. So it's not with what you're talking about. Then for conjunctivitis, okay, we have three types of conjunctivitis. We have allergic, viral, and bacteria. Allergic, they will always describe it as it starts with both eye. Allergic starts with both eye. And another thing I said in the video, you are going to have what? It's rope or stringy mucus, like a rope, like a stringy mucus, okay? And another thing about allergic rhinitis and conjunctivitis is they have what we call cobblestone appearance. All these things in the video, cobblestone appearance. Then we have a viral. Viral is watery discharge, water. watery discharge. And viral always starts with one eye, unilateral, before it can become bilateral. But both viral and bacteria are usually unilateral before it goes to bilateral. But allergic starts with what? Bilateral. So immediately they're asking you a question on conjunctivitis and they tell you patient complains both eye. So right away, you are going to be thinking about allergic, not any other thing. But if they tell you stringy mucus or stringy mucus rope-like, allergic. But if they tell you mucopurulent exudate, that is your bacteria. Okay, a lot of exudates. Another thing about bacteria is that bacteria will form like what we call sticky. It is so sticky and it looks like when they will tell you that they wake up this morning, they cannot even open their eyes. They have a lot of these mucopurulent exudates. Okay, so treatment is still viral and allergic is your antihistamine, while your bacteria is your antibiotics drop. So when you are talking about injuries of tendon and cartilage, the answer is usually your MRI, okay? So don't forget that they usually ask that, MRI. Okay, so MRI is usually used for soft tissues. So if they tell you that a patient came in, you have done all your examination and everything, but this patient still have pain, this patient still have pain, and you are suspecting tissue injury or ligaments, torn muscles, ligaments, what are you going to order? You're not going to order X-ray, you're going to order MRI, because some people still argue and they will tell you, but it says start with the cheaper one. It doesn't make sense if you're already suspecting tissue. There are questions like that and you don't want to fall prey. Even if you are supposed to start with cheap one, the cheap one is not the X-ray, because even if you do an X-ray, you are not going to see anything. At the end of the day, you have even made it more expensive because you do the X-ray, then you do the MRI. So that is not cost effective. But if you start right away with MRI, if you start right away with MRI, so if you are talking about soft tissue, so that kind of question in the exam, study it very well, because I have seen people say, oh, you have to start with something cheaper. That doesn't make sense, okay? Then what do we do with CT? CT is usually anything about bleeding, tumor, but questions on CT, you need to remember, if they tell you a patient have like you are suspecting like subarachnoid hematoma, subarachnoid hemorrhage, subdural hematoma, all those things, if you are suspecting it, what do you do? So if you are suspecting something like that, the answer is usually CT without contrast. Okay, CT without contrast, that is what they want you to know. CT without contrast, because as long as you are suspecting and bleeding inside the brain, we always use CT without contrast for the exam. Which of the following reflexes is elicited by allowing the infant's head to move back suddenly and when lifted a few inches off the mattress, resulting in anytime you hear the word abduction for FNPs and upward movement of the arm? This is usually your motor reflexes, your motor. because Moro is like, I call it like a fighting reflex. The child is trying to protect to protect his or herself from any danger, and they kind of do that abduction and upward movement of their arm, thinking that they can protect themselves, you know. But that is what the children or the child, whatever, the small baby does to try to protect from danger. So you need to know its moral reflex, and the exam can always ask you every FNP question you are going to see. So remember, so this moral reflex can ask you when should it disappear. At least from 4 months, it should begin to disappear. And it's very important so that you don't have any neurological issue going on. Okay, so know all your reflexes, routine reflexes. You know, when you put your hand by their side. Nurse practitioner is reviewing a patient chart before performing an examination. The previous provider said the patient had a normal Renin test. So where do we have Renin test? What are we checking for Renin test? Renin test is usually used for what? Acoustic, which is your age. Acoustic, which is your age. Acoustic, which is your age. Okay, which is your age. Acoustic nerve. Is terminal. So if they ask anything about trigeminal neuralgia, okay, the one that you have this unilateral facial pain, and they tell you that this pain is it involves the trigeminal and nerve, and I said the treatment is usually TT, trigeminal neuralgia tegretol, trigeminal neuralgia tegretol. And I said if a patient is allergic or patient cannot be given tegretol, what do you give? Answer is dilantin. If patient can get that tegretol, what do you give? Then you have 6. Your 6 is always the one that help with extraocular movement, which is your 3, 4, 6. 3, 4, 6. Okay, they're the one that help with extraocular movement. Then you have your 7. Your 7 is one that has to do with facial nerve. Your Bell's palsy is your facial nerve, okay? And also remember that Bell's palsy has something to do somehow, you know, when somebody have a Bell's, maybe there's a question on that. For Bell's palsy, you also have to monitor for corneal abrasion. The answer in the exam can be, tell them to apply the ointment and pat their eyes, because you are worried about what? Corneal abrasion. So that is the relationship with Bell's palsy and corneal abrasion. Okay, so that is your Bell's palsy. And what is the treatment for Bell's palsy? High dose of steroid. That is another place that we use high dose of steroid. Then the last one is your what? That is your age, acoustic. Okay. A 65-year-old patient presents with bilateral morning stiffness and aching that usually lasts up to an hour, primarily in her shoulder, neck, and hip. So when you're seeing this thing now, you should start telling yourself it has to do with arthritis, because the bilateral morning stiffness. But what type of arthritis is this? They said her ESR is elevated. That is the buzzword. ESR is elevated. The nurse practitioner diagnoses the patient with polymyalgia rheumatica, another buzzword. Which of the following is true? So if you listen attentively, polymyalgia rheumatica is associated with what? Temporal arthritis. So these are the kind of questions you don't have to overthink. The answer is here, looking at you. Temporal arthritis. And this temporal arthritis is when you have to be worried of what? Permanent blindness. Okay, that is because worried. So the option can be to educate the patient, to refer the patient to ophthalmologist. Okay, temporal arthritis. That's when I tell you somebody that polymyalgia rheumatica, every joint in their body hurts them. They will tell you them, oh, my shoulder hurts, my neck hurts, my hip hurts, everything. Okay. So these are simple questions. This one is so simple. It doesn't have anything to do with aortic aneurysm or all those ones. So you have this is another kind of question you have to. Okay. A 54-year-old patient with unknown medical history presents to the primary care provider. This patient had a general checkup. For a general checkup, since they haven't been seen in the past 15 years. Wow. The PCP performs a comprehensive physical exam. So look at what we have. Blood pressure 112, 122/81. Obesity, into something now. Obesity. The patient is not on any medication. The patient has darkened area around his neck. Interestingly, the ophthalmology reviews finding shown below. What was likely underlying etiology of these findings? So if you look at this question, it's just asking you about complication. It can be hypertensive complication, it can be diabetic complication. So which of the complication is he talking about? Is he talking about hypertensive or is he talking about diabetic? Remember I said for you to remember hypertensive retinopathy, remember it as CAR. All of them is in the video. C is your what? Copper wire arterioles. A is your AV nicking. When vein cross an artery on a fundus PSR. R is your retinal hemorrhage. Then there is another one we call diabetic retinopathy, which is your MCR. What is your MCR? Or you can put it MCR. It's your microaneurysm caused by neovascularization. Then C is your cotton wool spot. And R is your retinal hemorrhage. So from this question, they're telling us the patient is obese. There's something about this person has darkened area around his neck. There is something we call this darkened area. There is something we call this darkened area around the neck. And we say that is always common in people that are diabetic, people that have a metabolic syndrome. Remember, diabetic always goes with metabolic syndrome, and metabolic syndrome always goes with obesity. So if you look at all this question, patient is diabetic, patient has obesity, patient can also be at risk of metabolic syndrome. And we say that metabolic syndrome, they have what we call insulin resistance, okay? And it can also be associated with another condition, or you can rule out cancer of the colon. So that darkened area around the neck, darkened area around the neck is what we call acanthosis. All this thing is in the videos, okay? Acanthosis nigricans. That is what we call it. And another way we can call it, is a velvet thickening or velveteen thickening. They call it something like velveteen skin or skin patches, whatever you want to call it. But that is just that. So it's associated with one type of hypertensive complications. The answer is diabetic retinopathy. It cannot be hypertensive because this patient is obese. This patient have diabetes. So all this thing is pointing you at diabetic retinopathy, not hypertensive. You have ophthalmologic eye. So you can see that. Then we have another question here. This question is so tricky. A 30-year-old presents after sustaining a right knee heel injury 2 days ago. He was playing basketball when he injured his knee landing from a jump. He was able to walk off the court, that is the buzzword, but has had some swelling since. His knee does not hurt, but he has a decreased range of motion. He does not feel unstable and denies any clicking or grinding. He has no previous injury or surgery. On physical exam, he has some mild swelling, but no deformity. There is no pain on palpation except at the medial joint line. His range of motion is normal, inflection, but extension is limited. So that is the buzzword. Extension is limited. Extension is limited. He has a negative Lachman test. X-ray ordered in the office are normal. So what do you do? So I give you time to think, but all these things, you need to think very well. Extension is limited. Is limited. Somebody's extension is limited. Remember, this patient says he has some mild swelling, but no deformity. There is no pain. So we cannot choose and say there is no pain. There is no pain. There is no pain. That is why you need to think. There is no pain. There is no pain. So if there is no pain, NSAID is out. NSAID is out. NSAID is out. And we cannot do steroid injection. There is no pain. And it's just a mild swelling. So why do we cannot do steroid injection? So we are left with C and A. So your answer is A. If you put A, you are correct. That is so smart. Refer to orthopedic surgery. You know, you have to refer the patient because you cannot just start physical therapy. You refer. Knee extension is normally between 0 to 10, negative 10 degree. This patient injury is characterized by lack of extension, and that is why I keep saying limited to positive 10 degree. Positive 10 degree. I keep emphasizing on that. So that is your lock knee. Okay? So this is a relative surgical emergency and should be addressed within 2 days. locking may occur in meniscal tears as a result of torn flap. So the buzzword was range of motion is normal in flexion, but extension is limited. It's limited. So there is a locked knee. Okay. See how we were able to remove NSAID. Patient told you there is no pain, and they said mild swelling. So why will you choose a brace? Why will you choose NSAID? And they said steroid injection. This is wrong because nothing more, the patient did not have a severe inflammation going on. So this is emergency FEDEM, lock knee. Pay attention to this question. Okay, this is another smart question, smart. You see a 45-year-old man in urgent care who has hypertension, dyslipidemia, depression. I am on big list of medication, but I'm not sure of all the names. Also has a history of penicillin, that is just the buzzword. Penicillin allergy. He has not been a systemic bill in more than a year and denies recent hospitalization. When describing a treatment plan for acute bacterial sinusitis, you consider. So what is, when somebody is allergic, what do we give?
Excuse me, I'm sorry.
What do
Oh, okay. I didn't see the screen before, but now you're back.
we, so what for somebody that is allergic to penicillin? That is just the buzzword here. Patient allergic to penicillin, what do you give? You just do what we call try my flow. Okay? Try my flow. Try is your tetracycline. You can give them tetracycline, which is doxycycline. Remember, all tetracycline, doxycycline, all this lane, doxycycline. Mine is your macrolides, like azithromycin, clarithromycin, all those things, okay? And the last one is flow, fluoroquinolones. That is your flow, okay? So, but if you look at this question, that is why it's kind of, if you don't listen very well, somebody will jump to clarithromycin because it's macrolide. But don't forget, we are talking about what will you use to treat acute bacterial rhinosinusitis. So what is going to work better for somebody that have this? So that is what they're asking you. So if somebody is allergic to this, so what will work better is your doxycycline. If somebody is allergic, remember we're talking about allergy. Allergy to what? Penicillin. So somebody would have said amoxicillin with coagulate, right? Well, that should be, but like I said, these are the questions you have to be careful, because you might have the right answer, which we know. Some that have sinusitis, that the treatment is usually what? Augmentin, remember. And I agree with that. But they say that patient has allergic to penicillin. So somebody that is allergic to penicillin, augmentin also contains what? Selene, penicillin, selene. So this one is even out complete. Okay? So what will work better will be your doxycycline, because patient is allergic to penicillin. If patient is not, that is why some of these questions, there is no one way. If patient is not allergic to penicillin, the right answer should be your augmentin. Don't forget that. Augmentin is what we use for sinusitis, rhinosinusitis, because you can see it in another question, okay? But if patient is allergic to amoxicillin, like when they tell you that patient is allergic to sulfur, when a patient is allergic to sulfur, you cannot give them Bactrim. You cannot give them thiazide. So just remember some of all those medication that you cannot give, drug interaction. A 48-year-old was diagnosed with unilateral acute otitis media 10 days ago and treated with an antimicrobial. She is seen today with report of resolution of ear pain, which is wonderful. But with persistent sensation of ear fullness, and diminished ability to discriminate speech in affected ear. The anticipated finding on today's exam is what? So if you remember my teaching on acute otitis media, I said acute otitis media, when a patient comes in with acute otitis media, they are going to have this bulging tympanic, okay? But they said that this patient have acute otitis media. And after 10 days ago, the patient was treated. Yes, what do we say? The first treatment is usually your what? Amoxicillin. If you remember our guideline, right? A, 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 S, A, 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 S, okay? So acute otitis media, if they come in, what do you give them? Amoxicillin. If they come back after 3 months, you cannot give them amoxicillin, you give them augmentin. Okay? Even if they didn't come back after 3 months, if another question can be, when can they follow up? They follow up within 48 to 72 hours. And if they follow up in 48 to 72 hours and they tell you that this pain is worsening, or this condition is, or the symptom is bad, what do? You change it to augmentin. But if they didn't come back after you gave it to them and they came back in 3 months, what do you give them? Augmentin. Okay. Then if they come back, follow up, which is 48 to 72 hours, and they tell you they have what we call ear fullness. We say that is what? With effusion, right? That is acute otitis media with effusion. They have fluid inside their ear, okay? So now that is the problem this patient is having. Or they can also come back and they will tell you that they have something coming out when they sleep in. That is what short tympanic membrane. So either effusion or the tympanic membrane, a ruptured tympanic membrane. If it's ruptured tympanic membrane, tell them it's going to resolve. Okay. If it's effusion, you can give them Zotec, or like to dry the fluid inside, or you can tell them to monitor it. And I said that they can monitor it up to 8 weeks. Remember, all these things is in the video one night. Tell them to monitor it for 8 weeks, and after 8 weeks, which is now your 10 weeks. If they still have it after 10 weeks, then you have to treat them. Then you have to treat them with augmentin. But if patient is allergic to augmentin, what do you give them? Which is the other A. You give them azithromycin, which is a macrolide. Okay? Azithromycin. Then S is your strep pneumo. That is the most common organism. Okay? So with all we have said, what is the anticipated finding? So the finding is your what? Weber test will lateralize to the affected ear. So remember, it cannot be discomfort on tragus pool. Where do we have discomfort on the tragus pool? That is the one you have pain at the tragus. But we said the patient have otitis externa. We said patient have acute otitis media. So remember, the media is different from externa. Externa is also in the video. And I said externa is your OOCC, PP. Externa is when they have this outer ear pain, also known as swimmer's ear. Patient might be a swimmer, or patient, has to do with maybe constant using of earphone. And now all these bacteria, it might be as a result of mixture of water, if they are swimmer, or fungi, they go in the air. Okay, it might be that they are using their earphone, okay, constantly, something like that. So, and to be honest, that is one of the things that made me to run away from earphone, because I saw somebody that this thing happened to, and she almost ended up to have surgery, but she was lucky. So, but some things like that is also known as swimmer's ear. And we say that otitis externa, if you can give them ophaloxin drop, you can give them ciprofloxacin drop, you can give them corticosporin drop, you can give them polymyxin B, and the most common organism is your what? Pseudomonas aeruginosa. All these things in the video, please. Then we cannot say tragus pain. Tragus pain is your otitis externa. Okay. And we cannot say cervical lymphadenopathy. Where do we have cervical lymphadenopathy? That is your mononucleosis, that is your strep throat. And the difference is mononucleosis, you have posterior cervical lymphadenopathy. Why your strep throat, you have your what? Anterior cervical lymphadenopathy. So you just need to pay attention. That one is another topic of its own. When are they talking about mononucleosis? When are they talking about strep? Mononucleosis is a viral infection. You don't need to give them any antibiotics. You have to avoid AAA antibiotics. What are those AAAs? Ampicillin, augmentin, and amoxicillin. Avoid those 3A's antibiotics because of what? Morbilliform rash. Please don't feel overwhelmed. Everything I'm saying is in the video. Don't feel overwhelmed, okay? So that is your mono. And for mononucleosis, when a patient come in and the mother wants the child to play contact sports, they cannot play contact sports. You tell them they have to recheck the ultrasound. When they recheck the spleen, ultrasound of the spleen, if it comes back to normal size, then release the patient to play contact sports. That is the answer. Then mononucleosis, there are 4 classic signs you need to know. They have cough, they have pharyngitis, they have a posterior cervical lymphadenopathy, and their spleen, of course, is so enlarged. Okay. Why strep? Strep is, and another thing for mononucleosis you need to remember is what I call HEM. HEM, H is your what? Heterophile antibody test, which is also known as M, monospot. Heterophile antibody spot, heterophile antibody test. Then M is your monospot. E is your what? E is your Epstein-Barr virus, so it's caused by a virus. But strep throat, they have no cough. There is no cough in strep throat, and strep throat is usually anterior. Anterior. I am emphasizing on all this because that is how to pass this exam. If you don't remember the buzzword, you will tell yourself, but all these things looks like mono. No, all of them doesn't look like mono. And the exam will be specific. If it's posterior, exam will tell you. If it's anterior, exam will tell you. Okay? So there's no way we can be any of this. So the answer is Weber test. So what is Weber test? You know the Weber test, you know the Renin test. Weber test is the one they put on the head, okay? And when they put it, you try to, they tell you if they, when you stop, you know, making noise, then tuning fork, okay? Then the other one, Renin test, just remember Renin. For people that are confused, which one is Renin, which one is Weber? Weber is the head, okay? When Renin is ringing, when your phone is ringing, you do it at your ear, right? It rings in your ear. That is your renin. So renin, you are checking for BC and AC. And we say that renin, AC is greater than BC. Air conduction is greater than bone conduction, normal. Under normal circumstances, A comes before B in the alphabet. So A is greater than B. But when it becomes abnormal, B will become what? Greater than A. And we say that examples of such is when we have two conditions. When you're talking about this, we have conductive hearing loss and sensorineural hearing loss. What is your conductive hearing loss? Your conductive hearing loss is whatever you can see when you look inside the person's ear. What are the things you can see? You can see acute otitis media. You can see otitis externa. You can see cauliflower-like growth, which is your cholesteatoma. Anything you can see, that is your conductive. And if it's conductive, or even the simplest, which is your cerumen impaction, okay? But another question, please, I keep diverting because I keep remembering things you can see. For cerumen impaction, always remember they use hydrogen peroxide, okay? Hydrogen peroxide or normal saline to clean it, okay? Then that is that one. Then for cerumen impaction, renin test will be BC, will be greater than AC, okay? BC will be greater than AC for cerumen impaction, okay? BC will be greater than AC for cerumen impaction. Then we have another one. So cerumen impaction is your BC greater than your AC. But we have what we call sensorineural hearing loss. Sensorineural hearing loss is something you cannot see when you look inside the ear. An example of sensorineural hearing loss can be your something like nerve damage when we talk about acoustic nerve. It can also be as a result of all this ototoxicity medication. It can also be Meniere's disease. It can also be presbycusis. Okay, so things you cannot see. There's no way you will look inside the ear and you will tell me you saw presbycusis inside the ear. It's not possible. There's no way you can see damage of the nerve. Okay, so then what is Weber? Weber we have when it's normal. When it's normal. So remember the word normal. Okay, normal. When it's normal, okay, what do you remember? No lateralization. It doesn't lateralize. No. Just remember that word. No lateralization when it's normal. Okay? But when it becomes abnormal, which is the sample of this question we're talking about, when it becomes abnormal, it becomes, it lateralizes to where? To the affected ear. So the exam can ask you, under normal circumstance, what happens to Weber test? That is no, when it's normal, there's no lateralization, which is lateralizing. But when it's abnormal, it's going to lateralize to the affected ear. So if it's the left ear that have that impacted cerumen or whatever, it's going to go to that ear. So for the above mentioned patient we talked about, for the above mentioned patient, which of the following represents the best advice for this patient? I have said it. When they have the best advice is the sensation of ear fullness is an anticipated finding. That is the answer. When they come back, they have this ear fullness. That is with a fusion, okay? It's a normal finding. It's either they have ear effusion, the effusion, or they have tympanic membrane rupture. Those are the two things I said. You don't need to refer them to any specialist. That is out. You don't need to start them on any short course of oral corticosteroid. That is not how we share corticosteroids, okay? And you don't want to give them any other antibiotics, okay? The only thing you can give them if you are going to give them something is Sotex, something antihistamine, that is it. If you want to give them something. But normally they always tell them to continue, watch and wait, or reassure the patient. So that is why you tell the patient, watch and wait till 8 weeks, or it is an anticipated finding, okay? Remember, ear effusion and tympanic rupture. Adverse effects form of oral decongestants use include, this is the one so many people don't know. It looks so simple, but it's not simple. The answer is blood pressure, oral decongestants, okay? Oral decongestants. Example of all those, decongestants, all these oral decongestants, people have to be careful how they use it, okay? All these pseudoephedrine, pseudoephedrine, okay? They need to be careful how they use it. Even they have the nasal one, all these are frame, where they have a rebound congestion, also known as a rhinitis medicamentosa, okay? So it causes increased blood pressure because it causes a vaso constriction. So that is just the answer. It doesn't irritate, it doesn't cause nasal irritation, it doesn't bring down their pulse, not sedation. It's usually, it increases the oral form. Remember the buzzword, the oral form. So don't forget this question. It might show up again somewhere, somehow, when you don't expect it, can show up somewhere. Which of the following describes hearing loss associated with presbycusis? Presbycusis is very simple to remember, okay? Rapidly progressing asymmetrical in all frequencies, slowly progressively symmetrical, predominantly high frequency, variable in progress, usually unilateral, slowly progressive, conductive, bilateral. So let me give you time to think. So what is the answer? Bilateral, slowly, progressively. How can, if you use the word conductive, remember conductive we said is something you can see. Can you see presbycusis? So D is totally out because presbycusis is not conductive. Presbycusis, I said it earlier, is sensorineural. That is sensorineural. Something you cannot see. So if you use the word be, you are correct, because if you go for B, you are correct, okay? So never you choose anything conductive for presbycusis. I said it, presbycusis Meniere's disease, medication toxicity, all those things you cannot see. They are sensorineural, things you cannot see. Things you can see are conductive. I just finished saying it. So the answer is B. Even if you don't remember anything about presbycusis, always remember it's gradual, it's progressively, okay? It's gradual. Because with time, when you listen to my video, you will see the diagram. The man was telling the child or the son, what is he saying? He was standing right there with his son, but he's not hearing what the person was saying. So that is mostly common with elderly people, and it usually has to do with, if you don't remember anything, remember it always has to do with high frequency or high pitch, high frequency, not middle range, okay? High frequency, and it's not rapidly. So these are the way you can throw off the questions, the wrong answers. It's not rapidly. It's not rapidly. It happens slowly in the elderly. So once I see rapidly, this one is out. And once I see asymmetrical, this one is out. It doesn't happen only in one ear. It happens in both ear, both side. So you cannot tell me that it's better in the right ear, not in the left ear. No. It happens what? Symmetrical, not asymmetrical, not one side. Okay? Then B, slowly, I will choose slowly. Symmetrical, I will choose that. And predominantly high frequencies. That is the buzzword I always remember for presbycusis is high frequency. Variable in progress, not really. Usually unilateral, no. Mid-range frequency, bilateral slow conduct. This conductive have affected this option. So slow, progressive, symmetrically predominantly high frequency. Person can hear but cannot understand what is said. Everything sounds like noise. That is how to remember it. They have difficulty with conversation in noisy environment. Everything sounds like noise. Hearing aids can help. Okay. A 58-year-old man presents with complaints of bilateral itchy eye occurring intermittently. So if you look at this question, I know we have answered it before. We have answered it before. I said, we don't have to spend time on that. Where do we have a rope-like discharge? Rope-like discharge. And I told you the first thing you look at is bilateral, both eye. Bilateral, both eye. Bilateral, both eye. Okay, so this is so easy. I said bacteria, usually you will see unilateral. Viral, you will see unilateral. They can use the word unilateral to bilateral, but you will always see it with unilateral. It's only allergic. I said it again. Only allergic is bilateral. Once I see these things, you don't have to read all these things to continue. You already see bilateral. You already see rope-like. I said it's rope-like or stringy discharge. Bacteria is your mucopurulent exudate. Viral is your white discharge. Appropriate pharmacologic management option of allergic rhinitis, for 29-year-old machine operator includes all the following except. So I give you time to think. What can you give for somebody that operates, that is the buzzword, somebody that operates machine operator. You need to know that there are some of the medication for allergic rhinitis you cannot give for somebody that is machine operator, right? So what can you not give? I give you time to think. What can you not give to this patient? What antihistamine can you not give for somebody that is operating machine? What can you not give for somebody that is operating machine? That is the buzzword. You can give them loratadine. Loratadine is your Claritin. And Claritin doesn't cause, remember, they are trying to, they want about drowsiness. And that is why I keep emphasizing operating machine. Because somebody that is so the answer is B. You can read it up. This is the sedative first generation antihistamine, and it's effective in the treatment of allergic reaction. So this is what? First generation. And this is the same thing they said you cannot give. You are going to see it in another question. Something like a Benadryl. Okay. The generation. Okay. Because first generation antihistamine, or the first generation antihistamine, example is your Benadryl. Another one is this medication here, chlorpheniramine, okay? And your Benadryl. Let me put your Benadryl for you. That is another, under geriatrics, that is another question you are going to see for people that is doing adults. You cannot give them any of these first generation antihistamine. This question is a common question, but it's so easy to fail. It's so easy to fail. Elderly, but for this person, the buzzword was machine operator. I hope somebody's thinking. So, first generations, please don't forget this. Don't forget this. Don't forget what I'm saying. First generation is these two that I put for you. Then this loratadine, okay? Loratadine, which is your Claritin, or you can call it Claritin. And I'm just like telling us some common things you need to pay attention to. And another medication known as what? Cetirizine, which is your Zotec. I have said Zotec so many times here. I've said Zotec so many times. That is your what? That is your second generation. So when you see it in the exam, this is how this question is, but you can see it in another question. An elderly patient, what do you recommend? the answer is usually Zotec, because this is second generation. This is first generation antihistamine. Like I said, this is a common exam question. So no degeneration. You know, it's so funny how so many things are beginning to change. Also, like antibiotics, they can ask you degeneration for something like cephalosporin. Like you need to know degeneration. That is how some of things are beginning to change. Okay, so pay attention to generation. For elderly, we cannot give them B, we cannot give elderly B. But for this particular question, the buzzword here is that this is a machine operator. So normally when somebody operates machine, you always educate them, they cannot take this medication. That is what we normally do. Okay, so that is the buzzword. So it's a first generation antihistamine and causes CNS depression, which causes drowsiness. Patient education includes no driving, no operating heavy machineries. Let's look at another question. A painless ulcerated lesion with indurated margins noted on the lateral tongue. If you don't think well, you might not get this answer. Painless, that is the buzzword. Ulcerated lesions with indurated margins noted on the lateral tongue is accompanied by a firm, that is the buzzword, non-tender submandibular node in a 70-year-old man who is a smoker, 60-pack year old. What do you think? So what do you think? Let me give you time. What do you think? What do you think they're talking about? That is why you need to think. You need to think. You need to think. I'm giving you time to think to see if you can get it. Okay. So if you say squamous cell carcinoma, you are correct. This is not syphilis. This is not aphthous stomatitis. Aphthous stomatitis, we said patient have one large ulcer, okay, inside the mouth, one large ulcer inside the mouth. And we said that the treatment is magic mouthwash. That is your aphthous stomatitis. For the fact that they say to you, painless, firm, non-tender, this is tender. This is already telling you characteristics of a cancer. So even if you don't know what is squamous cell carcinoma, leukoplakia, I know somebody will confuse it with leukoplakia. Leukoplakia is non-cancerous, but it can be an early sign of cancer. Because somebody that have HIV can have leukoplakia, it does not mean that they have cancer. So it can be an early sign of cancer, but it is not cancerous. So we see it also in cancer patients. But if you look at this description, even if you don't know what is squamous cell carcinoma, you should know that carcinoma has to do with what? Cancer. And anything cancer is painless. Anything cancer is firm, it's very hard. It's very hard. Leukoplakia is patches, it's whitish, they can say hairy That is how you will see the description. Hairy white patches that refuses to remove. They always differentiate it with leukoplakia and what? Oral candida, right? The one we use, the nystatin, antifungi. So that is where they differentiate it. But even if you don't know what is carcinoma, carcinoma is cancer. Anything cancer usually is painless. Anything cancer is usually firm. Firm is the buzzword. Firm, non-tender, meaning it's not painful. Okay? And there is always induration, indurated margin. You know, these are the, or other things you can see about cancer is asymmetrical, asymmetrical, asymmetrical. So that is, even if you don't know anything about this thing, you're supposed to know. Okay? Somebody can confuse it with syphilic canker. Syphilic canker is a painless canker found in the first stage of primary stage of syphilis. But this is not talking about cancer. Syphilis is not cancer. Okay? So even though somebody will say painless, yes, painless, but you look at other buzzword, firm, non-tender. Okay. A 29-year-old woman presents with 6 hours history of sudden onset of inability to raise her eyebrow or smile on the right side. We just finished saying this. She also reports decreased lacrimation in the right eye and difficulty closing the right eyelid. The rest of the history, health history, and physical examination is otherwise unremarkable. This is likely what? Let me give you time to answer. Think about what you think is the answer. This is likely what? So what are we suspecting? What do you think is the condition they are talking about? And what nerve is affected? What do you think? What condition are they talking about? To answer. So what condition are they talking about? So this is 3, this is 8, this is 4.
And then 7.
So what we are talking about, inability to close their eyelid, inability to raise their eyebrow or smile, or that is your Bell's palsy. Okay, that is your Bell's palsy. So, and we said it already, Bell's palsy has to do with facial nerve. Facial nerve. If you say Bell's palsy, if you choose 7, it's correct. Facial nerve. And you have to know the goal for treatment, because they can ask you the goal for treatment. So the goal is usually to reduce the neurological damage, and I said it, prevent complication from corneal exposure. So if you're taking ANCC, they can ask you 2 medications, select all that applies to medication. The medication we use is usually high dose of steroid, corticosteroids, and antiviral agents. Antiviral agents, okay? And they, of course, they have to take care of their eye. They have to take care to prevent corneal drying or corneal abrasion. So you remember, if you're taking ANCC, they can ask you the 2 treatments. And I said steroids and antiviral agents, okay? which is your air cyclovia. Air cyclovia. Normal eye exam finding in a 55-year-old woman will include, what do you think? Normal eye finding in a 55-year-old woman, what will be normal? What will be normal? What will be normal? Retinal artery wider than the vein. Is that normal? Sluggish pupillary response. Is that normal? Is that normal? Normal eye. Think very well. Is that normal? Sluggish pupillary response. Is more. So if you choose C, you are correct, okay? If you choose C. Be found in the fundoscopy of exam. We have said this again and again, again and again. So which of the following can be found? Give you time to answer. Which of these can be found in angle closure glaucoma? I have said this so many times. So the answer is a cupped optic disc. AV nicking is your hypertensive. Papillary edema is also hypertensive. Like I said, papillary edema can somebody to rule out tumor or intraocular pressure, but the patient will have hypertension, but you still want to rule out hypertension, okay? Then your hemorrhagic lesion, which is your retinal hemorrhage. So the only thing here that makes sense for angle closure glaucoma, that is your A. So deeply cupped optic disc, you can look at it. If you're taking ANCC, you can look at this diagram very well because you can see the diagram and you have to say what that means. So a deeply cupped optic disc. That is it. Okay, so this one says it's greater than 18. Some books will tell you 22. So, but just know, depending on this kind of thing, they're not going to use it to confuse you in the exam. But just know if it's angle closure, send the patient out. If it's open angle, manage the patient because the patient is already under care of a specialist. So some of all these, millimeter mercury, some of all these things can have a little variation. Some book will tell you 22, Other one will tell you 24, but just know if it's greater that it cannot be managed, then you send the patient out. Then we have our AV leaking. If you're taking ANCC, remember the thing where an artery crosses the vein in a fundoscopy exam. If they ask you in a fundoscopy exam, artery crosses the vein, what is that? That is your AV leaking. And that is the papilloedema. It's like an area of swelling. You can see how swollen this place is. Papilloedema. Then you see hemorrhagic lesions, retinal hemorrhage. You can see it looks like if this eye is bleeding. Which of the following is used as a screening test for macular problem? What macular problem are we talking about? That is macular degeneration. Okay. Macular degeneration is common in old people, elderly. And macular degeneration, I said, you educate the patient to stop smoking. And for macular degeneration, how do you remember? C, they have loss of central vision. C, loss of central vision. So what do you give to somebody that have macular degeneration? You give them what we call Amsler grid. Amsler grid is like something with a larger print. Amsler grid. Tonometry is used for glaucoma. Okay, that is your tonometry. And we have talked about Chanel chart. So we have talked about Chanel chart. This sleep lamp doesn't have anything to do with macular degeneration. Okay. Slit lamp is used to identify corneal aberration. So when you're talking about corneal aberration, you are talking about slit lamp. Okay. Okay. A blood smear of a patient with likely infectious mononucleosis, what will you say? Let me give you time to answer. What will you say? Somebody that have mononucleosis. Mononucleosis, what will you say? Mononucleosis, what will you say? So if you say A, you are correct. Okay, you can read it up. You can read it up. A is the answer. The presence of atypical lymphocytes is probably the earliest indication of Epstein-Barr virus infection. Okay, it's probably the earliest indication. So that is it. Atypical lymphocytes or lymphocytosis. In the majority of Epstein-Barr virus cases, there is a leukocytosis of 10 to 20,000. Okay, so this is common. This is common. That is very common. So think about this question. Let me give you time to think about this question. Think about this question. So if you say C, you are correct. That is a long one, but if you say C, you are correct. Okay? But I want you to look at this question very well because we're going to use it to answer another question. A 72-year-old African American obese smoker with a past history of poorly controlled hypertension, diabetes, COPD, pay attention to this COPD, and hyperlipidemia presents to the emergency department with an excruciating, crushing, retrosternal chest pain that radiates to his left jaw and left inner arm. The patient states that the pain started about 30 minutes ago and its severity has remained constant. He vomited once on the way to the hospital. On physical examination, his pressure is 155/94. He appeared to be in severe distress and he's diaphoretic. A start X-ray was unremarkable, but a 12-lead EKG is shown. What is the most likely diagnosis? So we already know what is myocardial infarction. We know with ST depression, unstable angina, cardiac tamponade, but this is ST elevation myocardial infarction. And if you look at how it looks, because you might see something like this in the exam, something like this. If you are taking adult, please pay attention in how this look. So STEMI, like we know, we said all of us chose STEMI, okay, is a very serious type of heart attack during which one of the heart major arteries is blocked, okay? So it's really very serious type of heart attack, okay? MI, we know, is heart attack. So basically, this one, STEMI, okay? If you look at the diagram, depending on, you can see the diagram. You can see it in the exam, okay? You can just see how it looks like. Just something like this. I don't know how else to tell you, but just picture it in your mind in case you see a EKG like this and you don't know what is that. This is your what? Your STEMI, okay? And STEMI is a disease that arises from atherosclerotic of the coronary artery. Okay, all these things. But I'm glad every one of you got, you know, if you put STEMI, you are correct because it's not going to be cardiac tamponade. It's not going to be unstable angina. Unstable angina is something else. We have other types of angina, but unstable angina is, they have this angina even with rest, okay? So there's another question following that question. According to JNC 8 guideline, which antihypertensive medication is not appropriate to prescribe for that patient? Think about it. The same patient we talked about. What can you not give to that patient? What can you not give to that patient? Yes. If you say Carvedilol, that is correct because this is a beta blocker, okay? And remember what we said. This patient have, look at the sign again. This patient have COPD. I know about the other signs, but COPD is a major thing. So patients that have COPD, any respiratory issue, any respiratory concern, you don't want to give them, okay? You don't want to give them beta blocker. So that is the answer. You cannot give them beta blocker. Amlodipine is your calcium channel blocker. Remember your calcium channel blocker, 2 side effects to remember: constipation and your peripheral edema, also known as ankle edema, okay? Hydrochlorothiazide is your thiazide, and I said that thiazide is usually first line of treatment, but you have to look at the guideline. JNC8, the guideline says somebody less than 40 years is 140/90. Somebody greater than 50, greater than that is 150/90. But if it's American Heart Association, once their own is something 120 to 129, or some people can say 120 to 130. Okay, that is your American Heart Association. But remember, hydrochlorothiazide, if somebody is on is taking that and the person is on digoxin, if you remember the medication digoxin, what is going to cause toxicity? That is hypokalemia. Hypokalemia, because remember, chlorothiazide, they are removing what? Electrolytes. Okay? They're removing electrolytes. So hypokalemia will affect it. Then you have your lisinopril. Lisinopril is your ACs, and we say that ACs, the side effect is your dry cough and your what? And your angioedema. When patient is on ACs and they start developing some of all this dry cough, you can change it to what? To ABS. ABS is your Lexatan. So that is it. If you choose this, that is correct. Okay. A patient presents to your office or clinic with her 4-year-old daughter who just started pre-kindergarten. She said that her daughter has been complaining of headache and sore throat for a couple of days and has had a mild fever. She was treating it at home until she noticed some blisters. Pay attention, FNP. The blisters in her hands, mouth, and hands. She is concerned that her daughter has contracted something from a child at school. So what do you prescribe? Let me give you time to think. What condition is this? Patient have blisters. Where is that blisters? At the hand, at the mouth. Okay? Small blisters. Patient have mild fever. So what do you think is the treatment? Are we giving Tamiflu? Is this flu? Are we giving penicillin? Is this antibiotics? Are we giving antiviral? Or what are we going to give to this patient? So if you say D, you are correct, okay? The condition they are talking about here is your hand, mouth. Do we remember that? Mouth, is it the mouth, hand? You know, you're going to see all the blisters in their mouth, in their hand, okay? So in their feet. So all those tiny blisters. So the answer is D, hand, foot, mouth disease. That is what they're talking about. So you just treat with acetaminophen, cold flutes, and salt water gargle. So just remember what they are using for hand, mouth, foot, or hand, foot, and mouth, however they call it. So small blisters, okay? So it's not antibiotics. You cannot give antibiotics. So which sound is commonly associated with a patient with CHF? This is correct. This is simple. CHF, what do you, somebody that has CHF, is very simple. This is very simple. CHF, what sound do we hear with CHF? and giving us time to answer. Okay. So with CHF, we have S3 sound. Okay. And remember, S4 sound is your uncontrolled hypertension, left ventricular hypertrophy, also known as Tennessee sound. Also known as Tennessee sound. Okay. Also known as Tennessee sound. But your S3 sound is anywhere there is fluid accumulation, like pregnancy, like CHF. It can also be normal in a young athletic. Then you have your S2 split. S2 split is where we have our pulmonic, okay, which, and the only time you are going to refer S2 is when there is a pathologic S2 and it's a fixed S2, fixed S2. So we know what is patent ductus arteriosus, heart defect. So that is it. Your S4 is Tennessee sound. S2 is your pulmonic, physiological splitting. And we say that it's normal in an athletic. When a woman brings in an athletic child and you hear this sound, educate the mother that is normal. Your patient who was recently prescribed pravastatin, which is your statins, okay? Present for follow-up, complaining of extreme fatigue, dark colored urine. What is your best course of action? So what are we thinking of? Somebody on statin. Remember, somebody on statin. And this patient having dark colored urine, extreme fatigue. That is the buzzword. You see that word, extreme fatigue, dark colored urine. So what do? Do you discontinue the medication and order a liver function profile? Or do you obtain liver function profile? Or do you decrease the dose or collect urine, 24-hour urine?
Discontinue.
So this is, what condition are we talking about here? What condition? Rhabdomyolysis. Rhabdomyolysis. So when somebody is taking statin, okay, statin, so the answer should be they need to discontinue it. You can see the word discontinue or hold. Discontinue or hold, okay? And they will do the liver function profile. You cannot just choose A because patient is having rhabdomyolysis. So there's breakdown of muscles already. So you cannot just choose A, okay? So discontinue it, then do a liver function test. What is the most important source of iron, source of body's iron? Think before you answer this. What is the most important source of body iron? Important source. Most important source of Yes, if you say D, D is the correct answer. Recycled iron content from aged red blood cells. So you can read about that, but that is 80% of the iron is stored this way. And RBC are recycled every 90 to 120 days. 90 to 120 days. You advise a patient who is a vegan to supplement the diet. So somebody that is a vegetarian, what do you advise them to supplement? Is it vitamin A, folic acid, iron, vitamin B12? So if you say vitamin B12, you are correct. B12, B12, okay? You tell them to take a lot of vitamin B12. So let's think about this one. So let's think about this question. Think it before you answer it. It looks so complicated. This is kind of the way you will see it in the exam, but it's not complicated. A 76-year-old patient presents with fatigue, spoon-shaped nail. Once you're already hearing spoon-shaped nail, where do we have spoon-shaped nail? That is what? Iron deficiency, anemia, right? And if you listen to me, there is something we call this spoon-shaped nail. Spoon-shaped nail. What do we call that? Spoon-shaped nail. Because that is another thing you have to know. We call it what we call, another name for spoon-shaped nail is your clonachia, okay? But all of them is there. In case you see clonachia, that is your spoon-shaped nail. So, and we say that when it comes to iron deficiency anemia, iron deficiency anemia and thalassemia, they are under the same category. Iron deficiency anemia, thalassemia, and the lead poisoning. These three things, they are under what we call small. What is small? Microcytic hypochromic, like small. Hypochromics. Micro is something small. Hypo is something low, okay? Chromic, so small. So if you look at it, MCV is less. It's supposed to be within 80 to 70. If you're taking ANCC, they're not going to put this range for you, behind you, okay? But you just need to know, if you memorize MCV is 80 to 90 or 96, you already know. So if a patient have less than that, then that is your 70. That is your microcytic, okay? Then hypochromic. The hypochromic, the normal one is 31 to 37, and they have 24. So this is just it's just simple to interpret this lab. Okay, so they ask you a question. Oh, sorry. So patient that have this is the lab, okay? What do you think is the problem? I already said it though. So what do you think is a causative diagnosis to consider that kind of etiology? I said it, 3 things I mentioned. So what are you going to consider? Is that folic acid deficiency? No. Folic acid deficiency is your what? Is your, I will still come to that. Let me not say that. So the answer is gastrointestinal blood loss. So something is happening, bleeding is going on, okay? So that is correct, which will lead to iron deficiency. So it can be iron deficiency, it can be thalassemia, it can be lead poisoning, any of those things. It's your microcytic hypochromic, any of those things. Microcytic, hypochromic, okay? So that is it. So that is the test. You do other tests for it is a reticulocytes, ferritin, IBC. And also remember in the exam, they can ask you, the TIBC is usually elevated in iron deficiency because TIBC is their capability to gain more iron. So they are all wide open. They can take as many iron as possible. And that is why it's iron deficiency. But thalassemia, the TIBC is low, it's normal, sorry, it's normal because the problem with thalassemia is not iron deficiency, okay? And also remember that thalassemia, we have two types, alpha thalassemia and beta thalassemia. Alpha thalassemia is always common with A goes for A, Asian descent, okay? While beta thalassemia is always common with Black, Mediterranean, okay, or Greek, those things. Then we have another question here. In evaluating a patient with microcytic anemia, what lab do you choose? Microcytic, do you choose something like this? Is so simple. You're able to throw away B12 and folate because B12 and folate goes together. Okay. So somebody that you are worried about microcytic, which is the anemia, which iron deficiency we shared already. Iron deficiency anemia. So if you say ferritin, you are correct, okay? Ferritin. So ferritin is a better indicator of iron supply in the body, okay? So let's look at another one. Look at this one. A patient presents with 6 months of history of increasingly severe peripheral numbness. So when you start hearing of numbness, tingling sensation, numbness, tingling sensation, what are we talking about? B12, okay? It's usually your B12 and deficiency and folate, they are under the same group. But the difference with folate is they can always ask you something relating to folic acid deficiency. So that is, they can ask you, why do we encourage pregnant women to take folate in the first trimester? It's usually to prevent what? Neural birth defect. Neural birth defect. Then for folate questions, you need to know food that are high in folate that can help them. And you can also know that they give them medication, folate, right? Folic acid. Then for vitamin B, for folate deficiency, there is no tingling sensation. There is no problem with the nerve, no nerve problem, okay? But vitamin B12 deficiency, it comes with nerve problem, okay? So look at this. They have what we call macrocytic normal, large normal, okay? Macrocytic, look at it now, MCV, look at how big it is. Normal is 80 to 96, and they are in 132. But remember, when we talked about iron deficiency, here they were in what? 70. Okay, so these people is macrocytic, which is large. Did you see that? 132. Normocytic, normal, meaning normal is 31 to 32. They are within 32 to 37, sorry. They are within 32. So remember, macrocytic, normal. That is your folate and your B12, okay? Deficiency. The physical exam reviews pale conjunctiva and grade 2/6 systolic ejection murmur. So all this thing is just to confuse the person. Over the pericardium or cardium without radiation and smooth red tongue. So where do we have red buffy tongue or beefy tongue? Red beefy tongue. Red beefy tongue. That is your V12. Okay? It's not your iron deficiency. It's not your chronic disease. Okay? So that is your B12, also known as cobalamin. So this is another one you need to know. Let's look at this very careful. You see a 35-year-old well woman of Mediterranean ancestry. Even if I don't know any other thing, where do we have Mediterranean ancestry we were talking about? Is that iron deficiency or thalassemia? So even if you don't know anything about this question, for the fact you look at the MCV is low, which is your microcytic is low. Then 25 is low, which is hypochromic. Okay? So three conditions that is microcytic, remember, microcytic and hypochromic, okay? Three conditions we said is iron deficiency, beta thalassemia, and we said that thalassemia, we said that thalassemia is two types, alpha thalassemia, beta thalassemia. Alpha thalassemia is your Asian descent. Beta thalassemia is your black, B for black descent, Mediterranean, Greek. Okay? So if you say C, you are correct. So beta thalassemia, okay? Then look at another question. A 64-year-old woman with rheumatoid arthritis who is on DMARD. DMARD is a medication we use for rheumatoid arthritis, okay? Therapy, and continues to have significant symptoms present with the following. So let's look at this one. RBC, MCV 82, which is what? Normal. 80 to 96 is normal, so 82 is normal, right? RDW is normal because normal is less than 15, so it's 12.8. So what do we have here? We have normocytic, normochromic. So this one is your normal. Normocytic, normochromic. Okay. So where do we have normocytic, normochromic, normal? That is your where? Anemia of chronic disease. So don't forget these three things that I mentioned. I will sing it again and hopefully you will get it. Thalassemia, iron deficiency, lead poisoning is your microcytic hypochromic, small. Folate and vitamin B12 deficiency is your macrocytic normal, which is your large normal, macrocytic normal. Then you have another one that is anemia of chronic disease. For anemia of chronic disease and sickle cell, okay, we have normal, normocytic, normochromic. So this one, you have to treat the symptom for the anemia to be resolved, like renal disorder. If you don't treat the renal condition, the person will keep having anemia. So the anemia is not caused by iron deficiency. The anemia is not caused by vitamin B12 deficiency. The anemia is caused by something, an underlying condition, a comorbidity. So that is your anemia of chronic disorder, and that is your normal. If you cannot be able to differentiate this in the exam, there will be a problem to answer questions on this. Because they can ask you in the exam about iron deficiency anemia, which is the most common anemia in children. They can also ask you about thalassemia, and everything about iron deficiency anemia you need to know. You need to know about the ferritin. Ferritin is the first thing you can check. And another thing is the serum iron. Serum iron, it will be elevated once somebody start taking iron. So for example, if you put a patient on iron now, serum iron will be elevated. The iron in the blood, serum iron, okay? But the TBIC, which is the capacity to accept more iron, will still enlarge. It will take 4 to 6 months. And that is why most of iron prescription, if you look at it, is usually 3 months and checkup, or 6 months and checkup, but usually 3 to 6 months. So if the exam asks you, patient is on iron, how many percentage will you think it will increase by 1 month? And you have 1%, 2%, 3%, 4%. The answer is 1%, because 1% is just for 1 month. 1 month, there's not going to be any significant increase. There's not going to be any significant increase. The only thing that will increase is the serum iron, okay? Then we mentioned thalassemia. Thalassemia, I said, they don't have iron deficiency anemia. They are in the same category, but they don't have the same. Thalassemia, the TIBC, which is the capability to accept more iron, is normal. So in thalassemia, they don't need iron. They don't need iron. I am making emphasis on this because you are going to see it. They don't need iron. Okay? Then we have lead poisoning. Then after that, we have lead poisoning. Then after that, we have our vitamin B12 and folate. And I said B12 and folate is in the same category, macrocytic normal. Macro is large and it's normal, okay? But the difference is folate, there is no neuro involvement, there is no tingling, there is no numbness. But vitamin B12, when they start telling you patients have tingling, that is vitamin B12. And in vitamin B12, we have what we call red beefy tongue. Okay? Then we have the last group, which is your normocytic, normochromic. And I said normal, normocytic, normochromic, everything is normal. What does that one involve? That is your anemia of chronic disorder or disease and your sickle cell. When they ask you about sickle cell, they can ask you what it is. Then you need to know. And that is how the option will be. The option will be macrocytic normal, microcytic normal. All these cytics and cytic and cytic and cytic. If you don't pay attention to select which cytic they are asking you, is it macrocytic? Is it microcytic? Is it normocytic? Okay? So normal. In providing information about the best way to take oral iron therapy to maximize the drug absorption, what do you advise the patient? You know, this can be so tricky. So usually we advise them to take it on an empty stomach, okay? But the honest truth is that in real life, it doesn't really work that way. Okay, real life, you can tell them to take it with a cup of orange juice, but for the exam, empty stomach. Okay. So this is another long question, but try to answer it. Try to answer it. Miss Gardiner is a 70-year woman who presents with recent hypertension. Her blood pressure is 145. So look at this blood pressure. This man is 70 years old. And if you remember the guideline says that somebody, JNC age, somebody that is 70-year-old should be between 150 over 90. So it should be somewhere between 150 here. But this patient is 145 to 155, okay? Documented over 2 months on 3 different occasions. Her ECG and creatinine are within normal limits and she has no proteinuria. Clinical finding includes following. So the BMI, look at the BMI, is a little bit elevated. BMI should be usually 18 to 25, but this patient is 26. No S3, S4, no murmur. The PMI at 5th intercostal space. Fundoscopy exam is within normal, so everything is normal. In the past 6 months, she has increased physical activity by walking at least 30. So this patient is exercising per week and has cut back on dietary sodium. So this patient is on lifestyle management. In addition to counseling Ms. Gardiner to continue the lifestyle modification, so which of the following will you do? Will you advise this patient to add glass of red wine nightly while prescribing low? That is wrong. Okay. Add hydrochlorothiazide while encouraging weight loss. Inform the patient to switch to salt substitute to add to low dose AC inhibitors. So this is not right, and I'll tell you why it's not right. Ask Mr. Gardiner to return 3 months for blood pressure check with a plan to start drug therapy if there is evidence of target organ damage. That is wrong, okay? So the answer is B. So why is it B? We are adding, remember the guideline says 150. So somehow this patient is within the guideline. So what you just need to do, like I said, hydrochlorothiazide will reduce it. Some book will tell you by 8, some will tell you by 10, some will tell you by 12. But hydrochlorothiazide will reduce it by little. So if this patient starts on hydrochlorothiazide, it might bring it down to 140. Okay, so which is still good. You don't need AC inhibitor at this time. You don't need it because hydrochlorothiazide can function. But if this patient is like 180 or 170, something like that, and that is far away the guideline, okay? The guideline says 150 over 90. So if you said add hydrochlorothiazide, that makes sense. You are not starting any AC inhibitor at this time, and you're not going to encourage this patient to drink 3 ounces glass of red wine. Okay. So that is it. So according to JNC8, okay, persistent elevation above 140 over 90 recommends start off. So we can start hydrochlorothiazide. And another thing you need to know, if the patient is African American, when you start hydrochlorothiazide, after some time, if the blood pressure is still elevated, you can start them on calcium channel blocker for African American, calcium channel blocker. Okay. Then this is another question. Mr. Cat is 60 years old, 68. So what are his lipid goals? So if you look at this, is another one you have to play smart, okay? HDL is very low, 35. You always want their HDL to come up to like 40, 50, but this is 45. This is low. LDL is high because LDL, which is the bad cholesterol, you don't want it to be more than 100, but this patient is 150, okay? But the triglyceride is 210. You don't want their triglyceride to be more than 150, but look at it's 210. So what do you educate this patient? What do you tell this? What can you give to this patient? What do you think is the goal of management? If you know the guideline, you'll be able to. Are we going to start patient of fenofibrate, or niacin, or fish oil, or atorvastatin? Let's think. So the answer is D. So why is it D? This is D because you don't start somebody on fenofibrate or niacin. Fenofibrate, niacin, fish oil, all these things is the same word. And that is why if you know elimination method, you will eliminate these three things out because it means the same thing. Fish oil is over the counter. So that is even elimination method. But another thing you need to look at, the problem here is it's not the triglyceride. The guideline says if somebody has triglyceride even up to like 310, 350, educate them on lifestyle management. Okay? But when the triglyceride gets up to like 500 and above, 500, 600, 700, you start them on niacin, fenofibrate, fish oil to avoid pancreatitis. Okay, so you don't do anything at this 210. This 210 is still lifestyle management. Okay, it's lifestyle management. So you go and deal more with this LDL that is high because you want this LDL to come down. And remember, this is a 68-year-old. Okay, this is a 68-year-old. You don't want, and this patient have diabetes, this patient have hypertension. With all these comorbidities, this patient can be at risk for stroke if you don't take care of this LDL and HDL. And that is why we give them atorvastatin because that is a high density statin. Okay. So remember the guideline. If it's still anything below 500, it's lifestyle management. But if it's above 500, then all these three things is the same. So there's no way you should choose any of these three. With elimination method, all these three, fish oil, niacin, fenofibrate, they are all the same. It's just that fish oil is over the counter. Then the other one can be prescribed, but they are all the same. But with this patient, you are looking at the HDL. HDL is too low. HDL should be at least 50 or 40. You want it to be higher because that is the good cholesterol. Why LDL should not be more than 100, but it's 150. That is the bad cholesterol. So what we want to deal with, and this man is 68 years with all this comorbidity, hypertension, diabetes. If you don't take care of this patient will be at risk for stroke. So that is why we have to start them on high intensity statins, which is your atorvastatin.